Some of you can understand that. And I've known Shawna for a long time. So more than on the board, I'm a patient advocate and I'm very involved with the community. And I'm thrilled that Shawna was able to make this call. And I've known Shawna for about as long as I've known about CMT when my son was diagnosed, because she helped me get him diagnosed. And Shawna is at the University of Iowa with Dr. Michael Shai. She used to be at the University of Detroit. We've been up to both places several times. And she's a board certified genetic counselor with a specialty in neurogenetics and CMT. And she also works with people with Huntington's disease. She's extremely knowledgeable, cutting edge, and she's just a wonderful person. And when you go to that Center of Excellence in Iowa, it's like walking into extended family that actually love you and you feel very comfortable. So Shawna, thank you very, very much for joining us. How long have you been involved with CMT, and why CMT?
Yeah, so I became involved in neurogenetic diseases even before I was a genetic counselor. I worked in research and worked in that field, and so I was always kind of interested in neurology. So when I found myself along the path to become a genetic counselor, I was sort of known as the neuro girl. And we were rare at the time. When I graduated, only 1% of genetic counselors were working in neurogenetics. So because of that, I had to move to where the jobs were. And I made an unusual move. When I graduated, I was living in LA and found myself interested in a job in Detroit. So not a lot of people at the time in 2006 were moving from LA to Detroit, but made that leap and found myself working with Dr. Shai and helped develop the program there. And it's just been a great path along the way, meeting all of you guys and a lot of new faces here too. And being in this community has just been a great experience, both career-wise, but just it's just a really great community to be a part of.
Yeah, thank you for all your help. I meant really for the number of people that you see. We appreciate you so much and the knowledge base that you have. So I collected some of the questions before we started, and I just want to say, you know, the number of genes that have been discovered that cause CMT, what's that number at right now?
We're well over 100, and as many of you may have heard, we've just found a new gene, maybe one of the most common recessive forms of CMT that's out there. So the way that we're doing a gene discovery and gene identification has radically changed over generations, and so that's allowing us to find more and more. So most likely, based on our experience and opinions of people in the career or in this field, like Dr. Shai, will probably be upwards around 200 genes by the time we find most forms of CMT. So we're really still searching for many genes, especially for folks who have CMT type 2 or axonal forms of CMT. We can only find about or genetically identify about half of those for people with that diagnosis, but we know that they do have some kind of genetic cause to their disease. And so for a variety of different reasons in terms of, you know, how we evaluate them and things like that. And so we're still trying to identify that chunk, the rest of those folks, the cause of their disease.
So there are a lot of people in the community that, you know, tell us, oh, I don't know what type of CMT I have, and it's so frustrating, and I really want to know. Mm-hmm. And how long do you think that process will take? And I know you're not a mind reader and you can't tell in the future, but is the field of genetics just has exploded in the last 10 years. So are they finding new genes quite frequently? And those people who don't know what type of CMT, will they eventually get an answer?
I believe so, based on, I mean, that's one of our major aims through the Inherited Neuropathy Consortium. Is a huge part of our funding goes towards what we call whole exome sequencing. And that's a process by which we're trying to identify novel or new causes of CMT. and we can talk about what that is, and I have slides that can help describe what that is.
Let's talk about it right now, since you
Okay.
mentioned it. Exome sequencing, I really don't understand that. We've spoken about it, I've looked it up, but it's not in my head. And can I just go anywhere, like, and get a scan and my exomes are sequenced?
Yeah, it's not easy. No.
Tell us more about that. It's interesting.
It's if you think of genetic testing, there's different types of genetic testing, different approaches to genetic testing, and it's sort of like different levels that you would look at. So sometimes, if a lot of folks can think of, you know, for example, if someone's pregnant and they might have tested the pregnancy to look at, for example, chromosomes. Chromosomes are just sort of packages of genetic information. And so when someone's pregnant, sometimes they're looking to see if the pregnancy has too many or too little chromosomes. And so technically that's looking at genetic information, but it's looking at it from a really broad perspective, not looking at it in a very detailed perspective. It's looking at it to see, does someone generally have the right amount of information that they would need? And so when you talk about sort of the layers of genetic testing, you can get more and more and more detailed. But the more detailed you get, the more and more you find, because we're all unique and we all have unique differences. And so what we have to try to figure out is are those unique differences something that impact that person's, you know, medical life? So is that change causing their CMT, or is it just a benign change that does nothing, that just makes them a unique person? And so the more detailed you get, the more you find, and that's what leads to those, what we call variants of uncertain significance, rare changes that people just have that are unique to them, that don't maybe mean something, maybe mean nothing.
So I just want to interrupt you for a second. So you just said something that's really important about the variants of uncertain, is that significance, VUS? A lot of people get their testing back and they said there's been a change in this gene, a change in this gene, and people think that that gene that relates to a type of CMT, that's what they have. Mm-hmm. But I think it's more or less, we don't know what that change means. And it might be something else, or it still might be, but there's no scientific evidence to back that up. Is that true?
I would say it is. There's not enough sufficient evidence currently, because those things change. And they can change very rapidly in some areas, like in the cancer fields, whether something is benign or actually leads to, you know, types of cancer. The interpretation of those variants can change very quickly and has major repercussions for people in terms of what they would do and to manage their health. In the CMT world, you know, it doesn't change as quickly. So though that if you have a variant that we don't know what it means, we may not know for that year or the next year, but a couple of years down the line, we may actually be able to say, no, this is benign. It doesn't mean anything. It's not linked to your disease. Or we may be able to say, actually, this is suspicious. We've found other people with this. We think this is maybe something that's, you know, causing, you know, your disease. And then we would have to do, there's a lot of different evidence that you have to pull together to make sure that something is disease causing, because people make important decisions based on that information. And we want to make sure that we're giving people true information and not just assuming that because there's a change there that it's disease causing.
Right, so that's a blood test. Now, if I have a blood test and then I want to get exome sequencing, will that then verify the variant of unknown significance? And is it available to everybody? And
so that goes back to those levels that I was talking about genetic testing. So there's different kind of there's exome sequencing is available clinically to people, something that would have to be ordered usually by a physician. But in terms of the levels of testing, there's testing for CMT. For example, you can just test for the most common type of CMT, CMT1A. And so that's sort of the cheapest way to approach testing if you think that that might be the cause. And that's just testing for one gene. Or you can test for the 4 most common types. again, trying to help eliminate some of the costs sometimes. But from there, you can start to test for bigger and bigger panels of tests. Panels are basically what we call phenotype-driven testing. So phenotype just means we look at a batch of symptoms that are all together. So we would look at anyone who looks like they have symptoms of CMT, and we look at a clustering of genes that can all present that same way, and we put them on a panel together because all of those folks have a similar symptom presentation. And so panels are often offered now because it's a cost-effective way to approach genetic testing. But there's lots of labs that offer panels, and every panel can be different in terms of the number of genes that are on there and which genes are on there. So if you get tested at one lab and it's negative, you could go over to the other lab and get tested, and they may actually have the cause of your symptoms on that other panel. That would be rare, but it could happen because each lab has a different set of genes on their panel that's internally decided what goes on their panel. So what happens is that over the course of every year, as more genes are published, they may add more genes to those panels. And so panels can range from 80 to 90 genes to 300 genes, so they can get bigger and bigger and bigger. What we're talking about when we talk about exome sequencing is you throw out the symptoms, so you ignore the narrowing down of genes based on symptoms, and all you're testing for is every active gene a person has. So every protein producing gene a person has. So there you're just testing 20,000 genes, doesn't matter. Those genes can be linked to how development of an eye or other organ systems, but you're throwing out this whatever phenotype there is connected to those genes, and you're just screening for all of them to see if you can capture anything. When you do that, clinically, you have to decide whether you want to get a report for other findings that are not related to what you're doing the test for. So if you're going in for CMT, but you might find something out about your risk for Alzheimer's disease or something else. And so you have to decide, do I want to know that information? So those are decisions clinically that you would have to make ahead of time. And even clinically, if you have CMT type 2, even if you do a whole exome, your chances don't go up that you're going to find the genetic cause, because the clinical lab can only report back on what they know. So they can only report back on genes that they know are connected to CMT. They can't report back on any new genes or research or anything they're not doing any of those types of things. So that's where we enter in our project 6602, our gene discovery project, is actually we're doing exome sequencing, but we are looking for those novel genes. And it takes time, but we are finding and reporting back when we find a connection. And that's where our new publication on the SORD gene came out recently.
Wow, that's interesting. So you talked about the Inherited Neuropathy Consortium and this study 6602. I'm not sure everyone on this Zoom meeting actually knows what the INC is and why it's important to register with the INC.
Sure. And I can show some slides kind of showing what our consortium is, because I have our website, and then I'll go back to just chatting with you guys. But let me pull up my PowerPoint. So this was kind of going through exome sequencing. But this is the INC, this is our Inherited Neuropathy Consortium. So we're funded by NIH and the CMTA and MDA. So we have about 20 sites that all specialize in CMT in terms of being able to evaluate patients. All sites are cross-trained to evaluate folks the same way. We have infant scales, pediatric scales and adult scales that we use. And really one of our goals is clinical trial readiness so that we're prepared to have a network of sites that can run clinical trials through them when we have gene therapy trials and things like that, so that all physicians are trained and all evaluators are trained to test folks the same way. So it's a partnership between the clinicians and researchers and the families affected by CMT, so that we can all kind of join together and be ready when clinical trials are available. But also, we have a variety of different aims, and some of those aims are to help identify the genetic causes of CMT for those folks who haven't been able to identify with the testing that's currently available. And so that's kind of what I was talking about with the recent paper through the consortium, because you're joining so many different sites who are all enrolling families. So each one of these individual families, you can see here, these are individual, what we call pedigrees, or little drawings of families. And the circles represent women, and the men are squares. Sorry guys, that's just the way it is. And the colored in folks are the people in the family who had CMT. So until now, until 2020, all of these families had CMT, had a diagnosis of CMT, but they didn't know the genetic cause of their disease. And all of these individual people had been seen in various sites around the consortium and enrolled in the 6602 program. And we were able to identify a mutation in this gene, SORD, and connect all of them. And you can see how many of them there are. And this is, it's because recessive forms of CMT are more rare. This is actually a huge number of families to be affected. So this is going to be, this is a high impact. And the bonus of this is that knowing the genetic cause for this may have a rational pathway to treatment, which is kind of automatically puts us on an approach to treatment. So there may be clinical trials that come directly out of this. So again, all of these folks, last year didn't know the cause of their CMT, and then next year, the year after, might have an approach, be in a clinical trial and have an approach to a treatment. So that's kind of why Dr. Shai and a lot of the researchers in our program got interested in CMT, and I did as well, is because you can actually define, if you can genetically define the problem, because it's a genetic disease, if you can identify kind of the what's broke part, then you can kind of figure out how to fix it. And so wow, these are definable diseases because of that.
Wow, that's very, very exciting. And in our follow-up Zoom email, we'll give the link to the Inherited Neuropathy Consortium so everybody here can join.
Elizabeth?
Yeah.
Can I interrupt you for 1 second? Just to clear up some confusion that I've noticed that comes up in the community a lot. So we have about 35 designated CMTA centers of excellence around the country, and actually 4 overseas. And about, as Shawna mentioned, about 20 of those are INC designated and the rest are not. They're all being seen by a CMT trained neurologist, meaning neuromuscular is their subspecialty. That's what they studied during their fellowship. It's multidisciplinary, meaning you'll see other people, but of the CMT centers of excellence, of the 35, 20 are INC designated. So just to clarify the difference between the CMTA centers of excellence.
But everyone should sign up on this site, right?
Well, so this site allows you to find out which sites are INC sites, and you can go and you would sign a consent form that allows us to use your clinical data that you would do during that time. So you might have a clinical evaluation and everything like you have with a regular neurologist, but that information might be used also for research purposes. And there may be extra measurements that are done also for research purposes at an INC site. We also do have a patient contact registry. And I guess right now, however, because of we've had a transition in our data management center, that patient contact registry you can't sign up for yet, but
Okay.
yeah, it is helpful. We have about 5,000 members who are currently signed up. And when we do have like projects that we're working on, it's immediate. You get, hundreds of responses within a matter of a couple of days. So it's a very powerful tool for us to send out surveys. We've done surveys on pain. We've done surveys on uses of like what people are using for AFOs and orthotics, and what people like and don't like about those, because I know that's a huge, issue, with people saying, like they pay a lot of money for stuff they never use that sits in their closet. So that's one of the aims of trying to figure this out through our INC. We've been using the current registry as it stands, because we can't enroll new people yet, but we've been using it just recently to look at COVID-19 and see if there's higher risks for people with CMT for COVID-19. And it does not look right now, they're still doing that project, but that there was a higher number of people who contracted COVID-19, and there wasn't more significant risk factors that led to a higher number of deaths or anything like that in that patient population by using the registry. So it is.
So this is really a place where people can enter information, and you as scientists gather the information and then give us back more information about CMT and how it affects people, or what AFOs are best, and you can bring that back. So it's a huge help to our community.
Correct. Yes.
Right.
And once the registry is up and running, I will let you know. But
we'll let everybody on the Zoom list know, right? And
yeah.
Everywhere else.
Yeah.
Okay. Can we go back to the regular screen? Thank you, Shawna, for explaining that. That's really, really important.
Stop share here.
As we're speaking about testing, a lot of people think that they can, and maybe they can, and you're the expert. Can you buy a 23andMe test and figure out what type of CMT you have from the result of that?
So again, that goes back to different types of testing. And I think that people get confused when they think genetic testing, they just think of it as a one entity type of thing, but there's actually lots of different types. So medical genetic testing, which involves a doctor or genetic counselor that gets ordered, that's where you would find results for CMT. 23andMe, there's some testing like carrier testing that you can find out, and some limited BRCA1 and BRCA2 tests that you can find out through 23andMe, but that's not looking at a process called sequencing. So there's different types of testing. So that's what we call a SNP-based approach to testing. So it's a different type of test. And so it's really not going to find a lot of answers for folks with CMT. And so a lot of genetic counselors and people in medicine, talk about 23andMe and say people want to find out about ancestry or as something fun to do, or those types of things, but it may not lead to sort of medical intervention or management answers that they're looking for. And for that, you may want to see a genetic counselor or a physician to help guide you on the best approach to testing. Because we wouldn't want people to do that test and really not find out information that they were looking for, or in the worst case scenario, do testing and think they're free and clear of a disease when they actually could have that, down the line. And so that's kind of where it kind of can get a little bit tricky. So most CMT you would have to go through a physician or a genetic counselor and get like a medical test.
Right. Okay. Thank you for clarifying that. I really appreciate it. Someone asked me, it seems like in my family, CMT gets worse generation after generation after generation. Do you see that?
We see that people recognize the symptoms earlier and earlier once a diagnosis has been made. There are genetic diseases. You mentioned Huntington's disease, and that's one of the clinics that I also run here and work in research with Huntington's disease. But and that is a disease, a neurological disease that gets worse in every generation. But there's a genetic mechanism that causes that, and that process is called anticipation, and we don't see that in CMT for the reason, a genetic reason that I don't need to get into, but it's not something that we see in terms of a pattern in CMT because of that underlying genetic cause. But the fact is that people do, once establishing a genetic diagnosis, then people are starting to look for symptoms earlier and earlier because it's then recognized. And you can also have variability in a family. So I'm not discounting that. You can certainly have a child that shows symptoms earlier than their parent did, but it doesn't necessarily stand true that then the next generation is going to be even worse. That's just variability in a family.
That's a really good point. I never thought about it, because once you have CMT, you know the signs and symptoms, so then you realize you're looking for those signs and symptoms early on. But how do you explain that one person in a family can be barely affected, and then another one, same type of CMT, same family, is so much more severely affected, or all different types of severity? And how do you explain that?
That's a good question, and one that we've also tried to explore through the INC. So, for example, for CMT1A, the most common type, everyone with CMT1A has an extra copy or a third copy. So instead of having 2 copies, they have an extra third copy of the gene PMP22. So that's pretty clear. I mean, it shows you instead of having 2 copies, the person has 3. So they all should look pretty similar to one another because they all have the same cause. However, they don't. Even in the same family, we see more people with more severe symptoms and people with less severe symptoms. So we did a huge study called, it's a GWAS study, so it's looking for genetic modifiers. So essentially you are screening entire genomes of families with CMT1A and looking for other genes that can contribute to make some people's symptoms more severe and some people's more mild. So certainly there are going to be other risk factors, for example, environmental risk factors, or if someone has CMT1A and diabetes, that's been known to make their symptoms more severe because they both do damage to the peripheral nerve. But there are also underlying genetic modifiers that change the expression and cause those symptoms to be different from family member to family member.
So you think that one of the questions was, do you think there is an environmental cause as to why some people are more severe than others in the same family with the same type of CMT?
There probably are. I mean, those are things that are much more variable and harder to define. So looking at, a genome in one individual or, a bunch of individuals is more definable than like where they grew up, what they were exposed to, levels of exercise that they've had during their lifetime, or other variables that, whether they have metabolic disorders or those types of things that would, so things that with other healthcare, comorbidities and stuff like that might challenge the system or the body. And so those, you get into a lot more variables that are hard to tease out.
Sure.
But it is something that we're looking at. So another one of the new aims of our going forward in our next 5 years of the INC is a sensor project to actually have people who come to our clinic and get evaluated be issued sensors that can allow us to measure mobility and exercise levels and how those things are impacted by CMT, and kind of try to get a better idea of what overall kind of life is like with CMT, and it allows us to develop, again, better outcome measures.
Boy, it's interesting. We know so much, yet we have so much more to learn, right?
Mm-hmm.
There's still a lot of questions. Some people say that they have 2 or 3 types of CMT. What are the statistics on that? Do you know? I'm sorry, that's just pulling, I'm asking for statistics and numbers, which I didn't give you the heads up on that.
It's rare, but CMT is one of the most common neurogenetic diseases there is. I mean, it's up there with neurofibromatosis, which is a very common neurological disease, MS, which is a neurological disease. It's not genetic, but we don't have genes that we know cause MS, but I mean, so it's very common, but it's just a very common disease no one's ever heard of, I guess. So it seems sometimes. But so it is possible that people, and we've had patients or families that had two types of CMT in the same family, but you know, those are only a couple families over the thousands of people that we've seen over the course of, you know, these years. So it is rare. And I think where the confusion lies is that when you go and look up, you know, a type of CMT, for example, CMT type 2D, if you look that up online in OMIM or some of the places where you would find information, that type, I mean, they can list 4 different names to that one gene, for example. And so I think that's where the confusion is that people get, one physician or one provider will call it one thing, and another person will call it another thing. And so it really comes down to who you saw or what you looked up online, and it may not be all these different entities.
Right, so there again, the necessity to see a genetic counselor and a neurologist or for the right information.
Right.
You know, it's tough. There's a lot of information out there, but sometimes too much is confusing. So, you know, in this era of COVID, a lot of people are asking, is CMT an immune compromising disease?
And we have not seen that, but, you know, we know that there are some forms that are more severe, that are rare, that may have a respiratory component, although we don't really understand that. And we do have a project that's looking at pulmonary function funded by the CMTA that helps to evaluate what type of pulmonary function can be impacted by CMT. But, you know, like I said, we're just starting out to look at things like COVID-19 and stuff, since this is all new to us, and using those powerful tools like the patient contact registry. And there's not been any evidence based just on that initial survey. And we plan to follow up with follow-up surveys that there was any additional risk factors either to contracting COVID-19 or being at higher risk for more severe disease. So you know, the answer is I don't know that it's completely understood, but I don't think that there's any obvious.
Okay. So then I received another question, which was intriguing. You know, this person has HNPP, which is a type of CMT, but she said her mom has a different type of CMT. Is that possible? Maybe a CMT 1B or something like this.
Mm-hmm. Well, I think it might be because, again, of how things are named. So HMPP and CMT1A kind of go a little bit hand in hand if you think about it. So CMT1A is that one that has 3 copies instead of 2 of PMP22. But HMPP is where you have a missing copy of that gene. So traditionally for people with HMPP, they only have 1 copy of that gene. So we know for PMP22, for that gene, it's a dosing problem. You need the right amount. You need 2 copies of that gene in order for that myelin to function, so that for that nerve to function. And too much or too little is not going to work. So CMT1A is too much, HMPP is too little. But then there's a little wrench thrown in there, is that some people don't have an extra copy or a missing copy. They actually have a spelling mistake, what we call a change or a mutation in their PMP22 gene. And that can do a lot of different things depending on where that mutation is. So it can make someone look like they have CMT1A, because that looks a little bit different than when someone has HMPP. It can also make someone look like they have HMPP. It can make them look like they have a disease, a type of CMT that's even more severe than both of those. So it depends on where that change is in the gene and the type of change. And sometimes people refer to that when there's a sequence change as CMT type 1E. So there you go. There you go. Now there's a whole
you have
other
3
name
types of CMT.
there. So if someone has a sequence change in that they've inherited in their family in PMP22, and they look like someone with HMPP, their doctor might say, well, you have HMPP because that's their symptom presentation. But their parent may go and have that testing and their doctor will say, well, you have CMT1E because you have a sequence change in your PMP22 gene. And that's how two different people in the same family got 2 different disease names.
That's very interesting. Thank you. Another common question we receive at the CMTA is CMT runs in the females in our family, generation after generation, or only runs in the males. Is there a type of CMT where it only runs in the females, or is that just chance?
It's chance. I mean, there are some hallmarks of certain types of inheritance patterns, which I can go through quickly, but it might help to show my slides again, just to show inheritance patterns. And this might answer a few of the questions that you had on the list. So
okay, let's do it.
And I don't mean to be too tedious to folks, but inheritance patterns get really confusing to folks. So a lot of the questions that were tossed in ended up being about, can this start out brand new in a family? How can I get CMTX from my mom? These types of things. And so all of the answers to these types of questions are answered by inheritance patterns. And I'm happy to, if questions come up, answer through this process, but let me go back to my,
And I think after we go through the inheritance part, I think I'll go to questions from our meeting attendees, because this could be an all-day meeting. It's so interesting.
Let's see if I can pull this up. Here we go. All right. So I'm just going to review quickly so we're all on the same page.
I raised my hand, right?
Someone have a question? Okay. So remember that, so our genes are kind of held on these structures we call chromosomes. So these are just pictures of chromosomes here. And chromosomes come in pairs. So we get one of each pair from mom, one of each pair from dad. And whether we're male or female, the first 22 pairs are the same. We should have 2 copies of each of those, and therefore have 2 copies of each gene on the first 22 pairs. So for example, PMP22 comes on chromosome 7, is inherited on chromosome number 17. And so that should she should have 2 on each copy of each chromosome, but some people have a duplication or an extra copy of that. And so they inherit 3, or they might have a missing copy and then they can have HMPP. The only difference is between men and women are the last set, the 23rd, that people have, women have 2 X chromosomes and men have an X and a Y chromosome. So the Y chromosome is what makes them males. And this impacts CMTX because it's inherited on the X chromosome. And so we'll get into what that means. So most forms of CMT that we see in the US are dominantly inherited. So that means that, for example, with CMT1A, there's a mutation, or for example, an extra copy on one of those chromosomes. So this is the two chromosomes here. And on one of those chromosomes, there's an extra copy of that PMP22 gene. And the other parent's genetic information does not matter. In this case, in dominant inheritance, every time someone passes on a child, they're either going to pass on the chromosome with the extra copy or the one with the normal copy number. So the one with the mutation or the one without. So that's why there's a 50% in dominant inheritance whether you pass on CMT or not. And the gender of the child does not matter in dominant inheritance, because again, we're not talking about the X or Y chromosomes.
So Shawna, we're talking about most of the CMT 1s and 2s in that category for autosomal dominant.
Correct.
Okay. I hate to make broad generalizations, but mostly if you have CMT 1A, 1B, you're talking about this type of inheritance, 50-50 chance passing it on.
Right.
Okay.
And this is usually what you would see, although even in, so you have a parent and every time they have a child, they have a 50% chance of passing it on. If that child does not inherit it, they cannot pass it on, it ends there. If that child does have it, then they have a 50% chance of passing it on. Although even in dominant inheritance, you can have it start out brand new in a family and you may not have any family history, and then someone has a mutation or change brand new called a de novo mutation, and that's where it would start out brand new in a family. So this is not always what you see, but this is a lot of the time what you see. X-linked inheritance, so this is where that question came in, where, you know, getting X-linked disease from my mom, that is possible. So with X-linked CMT and other X-linked diseases, when a mom has it, she has 2 copies of X chromosome and the mutation is on one of those. So again, does not matter which gender the child is. Every time she has a child, she's either going to pass on the chromosome with the mutation or the one without. So it's a 50% male or female for each child, whether the child's going to receive CMT or not. It is true though that with CMTX specifically, because mom has 2 X chromosomes and any of her daughters would have 2 X chromosomes, that generally speaking, they may be milder than the males in their family because they have that second X chromosome in that second gene, but that's not always the case. They can also look like they're the males in their family. Different than if dad has CMTX, because dad is the one that determines the gender. So dad's only going to pass on his X chromosome to daughters, and will because the Y chromosome determines the males, so male child. So if dad passes on an X chromosome, that child is going to be a daughter, but will also be affected because it has to have the mutation because dad only has 1 X chromosome. If dad passes on the Y chromosome does not have the mutation, and that person becomes a male child. So this is the hallmark of X-linked inheritance, where you have no male-to-male transmission of a disease. A father cannot pass on CMTX to a male child. And also, conversely, will have to pass on CMTX to all of his daughters. So 100% of his daughters will be affected, 0% of his sons will be affected, versus mom, we're 50-50 no matter the gender.
Okay.
And so that's when you see pedigrees like this, where you see no male-to-male transmission, but you see all of the daughters of father being affected. And then you have X or recessive inheritance. So these are lumped together in CMT type 4s, and that's where parents are carriers, and you may not see any family history, but they would each not have CMT themselves because they have another working copy. But in this case, in order to show symptoms, you have to inherit changes on both copies of your chromosome in both genes, and that's the only way you would show symptoms. So if parents are carriers, they have a 1 in 25% or a 25% chance or a 1 in 4 chance of passing on the chromosome with the mutation to their children. So in this situation, 1 in 4 children statistically would be affected, but you can have like 2 siblings and things like that, and the parents being healthy and not having CMT. 50% of their kids would statistically be carriers like the parents, and then there's a 1 in 4 chance of not them being unaffected non-carriers. If someone has a recessive disease, because both copies of their chromosome have a mutation, all of their kids have to be carriers. But if their partner does not have the disease, then they can't be affected. And so that's where you see this type of inheritance where you have no one affected anywhere in the family. And then all of a sudden there's going to be a person who starts to show symptoms. Recessive forms of CMT traditionally in the past have a lot of times been more in childhood. And but remember, you can also see this type of inheritance pattern when it's a brand new de novo dominant mutation. So you have to be careful about that. So when I do a family history and I see this, until I know the genetic cause for this person in blue, I can't tell them that it's recessive or dominant. So I can't tell them this could be close to 0% chance of passing it on to their kids, or it could be up to 50% chance of passing it on to their kids. Until I know the genetic cause, I really can't give them any more information than that.
Wow, that's great. Thank you.
Very helpful.
You know what I'd like to do? Thank you so much. That was a great basic explanation and put things into perspective. Very, very, very well done. Thank you. I do have a couple more questions, but I do want to take questions from our participants. So, you know, raise your hand or, and then maybe we'll start with Denise. If you have your question, Denise, and then we'll go on. Laurel, you can pick out the questions.
Yeah, because we have a few hands raised. So do you want to unmute yourself and go ahead?
Yes. Yeah, thanks. My question is about INC and registry for INC. And my family, a number of us have been at the clinic in Iowa a number of times. So if we've been to the clinic a number of times, are we automatically registered with INC?
They are, so you are in the, you're involved in the consortium, and you would find out when clinical trials are available to you based on the type of CMT that you have. And there's data that's being directly collected from your evaluations and put into our database to develop longitudinal studies for different forms of CMT. So these things are very important, and why we partner with folks with CMT in the community, because in order to know if a medication is working or not when we get to clinical trials, we need to know how the disease typically progresses so we can know whether we're slowing something down or stopping it. So even though natural history studies and like studies where people are involved in over the course of years, they're not flashy, and we're not giving anyone any medication or anything, but they are vital to moving forward with clinical trials because there's so many different types of CMT. It's important to have as many people as you can getting evaluated in a systematic way so you can measure that change over time, and then you can compare that pathway. You can compare how much that disease or that type changes over time to when you put those folks on a medication and see, are we having an effect? Are we slowing it down? Are we stopping it? Or is this doing nothing? And so really that is an important part of this as well, but it's a separate part than the patient contact registry, and that people can be involved in both, but those are more sort of survey based. You can do it once or however many times you want. Those are to develop quality of life measures or to figure out what people, like I said, want in their orthotics or devices, or what people, there's been, you know, questionnaires that have gone out about to help us understand what people see as symptom severity in CMT. And so there's just a lot of feedback from the community that we get that way. And I don't think people get inundated with questionnaires, but I think it's a very powerful tool, because researchers can, if they have an idea or a pilot project and they want to try to hone that in, or if you want to get an answer right away, you really get hundreds of responses, 400, 500 responses within a day or two, because this is a very responsive group. So, so that's another powerful tool, and they are used separately to answer different questions.
Thank you.
Okay, just for clarification,
Yep.
I've been to the Iowa clinic a number of times. Does that automatically put me on the list for INC, or do I need to go in and register myself?
You're in the INC, and we are collecting your data over time, and you would be contacted when you're eligible for a clinical trial or things like that in the future. But for the patient contact registry, that's all online. And so that's a separate thing that people you don't have to come in for. So that captures not just people who've been into INC, but that are just online and maybe can't come to an INC site, or just that's the level of involvement they want to have. And so they sign up online, and they're through the registry, then they get those surveys once in a while, things like that. So that would be a separate step, but it's not something that you have to do in person. Everyone who does come through the inherited, like for our people who come through our site, there's a blurb on the bottom of their after visit summary that says join the patient contact registry, and it has that information, and it has the website and stuff like that. Maybe we don't do a good enough job promoting it, but certainly people can be involved with both, but they're both kind of separate.
So if you've been to the clinic, then still join the patient registry. They're two separate things, and it's beneficial to do both. So thank you, Denise, for that question.
Okay, thank you.
Elizabeth, we've had a few hands up for a long time, so we
Go
will
ahead.
to everyone, but Jojo and then Krista Farrington. So Jojo, go ahead.
Hi, yes, mine is more, I'm in the middle of family planning, and I've gotten a genetic test done. I think it was CMT full panel, they said, through that Invitae. I'm not really sure how you pronounce it, but I think a lot of people go through them. And it came back that my GARS gene was affected, but it says insignificant variants or something along those lines. So I was wondering, does that mean if I wanted to do that PDG testing, that means that we still don't have the full information on that?
Yeah, it's, so you have to have sort of a confirmed genetic cause in order to do things like PGD. So PGD is pre-implantation genetic diagnosis. So it's testing on an embryo prior to pregnancy, and then selecting embryos that don't have a mutation and moving forward with a pregnancy based on that. And so they will not do testing on an embryo with a variant of uncertain significance, because they don't know what that means, and they don't want to make those types of decisions and selections, because you might even be selecting for the wrong thing. So you could, could be something else that's being passed on that's actually the cause. And then you may still end up with a child that has CMT because you tested for the wrong thing. So that's what I was talking about, the impact of really knowing whether something is disease causing or not is that significant, that we have to be certain enough to know that someone's going to make these types of pregnancy planning decisions based on the information that we tell them. And so there are GARS variants that are benign, that don't do anything. There are GARS variants that are or mutations that are disease causing. Going to one of the INC sites can help guide you and tease that out, because we'll match your clinical symptoms with what that variant says. The Invitae panel is good and cost-effective approach. It's not the biggest panel of the bunch, so you're certainly missing some of the genes out there when you do that. So that's why I was talking about the pros and cons of some of the panels out there, and knowing what the pros and cons are, and working with a genetic counselor can sort of help guide you in that. But often as a genetic counselor, we're trying to be cost-effective for people. So I do use Invitae, knowing that, I'm maybe not capturing all the genes, but knowing that I'm getting most of them for people, just because it's the most cost-effective way of doing it. But that panel might change in a year or 2 years or 5, so these are changing all the time. So please don't say that this will, a year ago, Shawna said Invitae is not really good.
Yeah,
I use them. But they just change all the time, and so it's really not a one-size-fits-all sort of scenario.
Okay. Thank you, Jojo. Krista Farrington, thank you for your patience. Go ahead.
Yeah, hi. I just had a question. I'm wondering about the genetics when it comes to other things. Like, I'll give you an example. My father had depression, and we know that some depressions can be genetic. But it seems like with his, he had CMT, and he had depression, and it's been passed on. Those that have CMT also have depression. Is there a link genetically with that?
For depression, it's more complicated because generally depression is common in the population. So there probably are genetic risk factors, as there are for other types of mental illness, like schizophrenia and bipolar. Those are kind of some of the types of mental illness that have the highest cofactors or highest sort of like what we see genetic kind of risk factors. But depression is just more common in the general population. So genetic studies have thus far been a little bit more complicated to do because it's hard to isolate that. You don't know if you're testing everyone who has a genetic cause or those people that have other risk factors that are causing, depression. So there's not been a known link of depression that's caused by the genetics of CMT, but there is a risk of depression just by living with CMT. Any chronic disease puts you at higher risk for depression because for many reasons. I mean, for the fact that every day it takes you longer and more energy to get from point A to point B. People have to focus more of their energy to do so. It's sort of a hidden disease. A lot of people don't understand it or don't understand what you're going through. I mean, these are things that the community has told me. So, and these all causes an additional stress that people have to live with. And so it just sort of puts you a little bit, over the top when dealing with the just everyday stressors of life. And so anytime we're in a situation like right now, COVID-19 and stuff like that, it's just one more thing to deal with. So certainly depression, we see that in the symptom presentation of CMT, but it's not necessarily genetically caused or linked. And there's not really a known genetic links to depression because of it's so common in the population. Does that make sense?
Thank you, Shawna.
Yeah.
That was a great answer.
That is that's a great question. I'm gonna keep moving if that's okay. So,
I want to ask everyone, especially Shawna, are you okay to go to 10, 15 more minutes, or do you have another obligation?
I didn't realize we were at time. So.
I know, crazy, huh? It goes by. Do you have another 10 minutes to stay on? Because there's
Sure.
a couple more questions.
okay, so, and also if we don't get to you, so Jojo, we probably won't get to your second question, I'm sorry, but if you could email me, then I could get those to Elizabeth and Shawna. Robin's daughter, Robin, do you guys want to go ahead?
Yes, hi. So my son was just recently, through genetic testing, we found out that he has CMT type 4B3, and as you said, with these like more rarer types of being a double recessive CMT, we don't really know much about it. Have you other people like with this type? Like, are there any clinical like trials? Like, what should we be doing?
I think so. Yeah, reaching out to the INC sites is a good start, and going through one of the clinic sites for that is a rare disease. So SBF1 is the gene, and there's going to be not that many people, and not many patients to compare to, and because of that, you're going to see a lot of differences between one patient to another. Okay, because these very rare diseases are mutation specific a lot of times. So there's, your child's mutations may be different than what's out there in the literature in other kids. And so making direct comparisons are going to be more challenging. So it's going to some of the specialists and working through them and sort of seeing what they recommend. It's also very difficult to do predictions, obviously, in someone who's 3, but we do have measures that can start out, and infancy measures and things like that at that age. Some types of CMT, there's kind of a good publication that came out that talked about sort of more complex types of CMT where there may be other features that can sometimes pick up so it's not necessarily only a peripheral neuropathy. There can be other features that kind of go along with it. But again, those are very challenging to predict in a 3-year-old, especially in a rare condition. and what you would see in one person is not necessarily what you would see in another. So, you know, you can read in the literature, but if it's not exactly the same mutation, and even then it may not be exactly a good predictor of what you're going through. So educating yourself is good, but moderating that with understanding that it's not a crystal ball and it won't really tell you exactly because of all of those things that I mentioned. So I think connecting with the specialist is a good starting place, especially if you don't have that in your area. So to get to work with people who've seen those types of rare diseases before.
Thank you.
Robin's daughter, sorry, I keep calling you that, but if you reach out to me, I should have gotten an email from me. I don't know if you're in New York as well, but in Rochester, Dr. Herman is an INC, correct, Shawna?
Mm-hmm.
INC, so there's, that's a great option for you. I'm going to move on. So Eugene, you have been incredibly patient. If we had a patient award, we would give it to you. Please go ahead. Oh, you'll have to unmute yourself.
Okay. I'm speaking on behalf of my daughter, who's an adult but not unable to be here. She has, according to all the information we've gotten over the years, CMT2A. However, there's some features that are not even described as CMT2A, and her problems have been progressive, but she also has a daughter with CMT2A, which has been genetically proven, but it is changing, and we've had some subsequent genetic tests. What I want to ask is, first of all, she's well known to Shawna and to Dr. Shai because she's been years ago been to Detroit several times. And however, Iowa got a little bit too far away for her to travel. Traveling there is an enormously difficult, traveling anywhere is enormously difficult. Confined to a wheelchair, she has difficulty with her respiratory or respirations, paradoxical diaphragm movements, and she's now losing her vision. So I want to know, is there some way, first of all, clinically, where does she get help? She's been from pillar to post. There are people who claim to have a clinic and then sort of fade away. I want to know about INC, and is she registered? Or can she register in INC? I would also like to know is there some way to predict, or I hesitate to speak to my granddaughter because she sees her mother and she sees that she's only 20, but her mother is in her 50s and having serious problems. She, by the way, she works full time.
And she's a Nova.
And is now her genetic picture is that we have 5 children. My 4 oldest sons are not affected, at least not clinically, and my wife and I are not affected in any way. However, we are now going to submit our material for genetic determination because we realize now that even though we have always thought that over the years she's a de novo mutation, maybe our genes had something to do with a de novo mutation, as Shawna was describing. We may have some.
Thank you, Eugene. Maybe you can give some answers to his questions, Shawna.
Well, it is most likely for CMT2A, so every type again is different. For CMT2A, about 50% of those are de novo. It has a little bit to do with the severity of the disease and things like that. So that's a little bit, it's more specific to CMT2A than, for example, CMT1A. Only about 10 or 20% of those are de novo. So there's differences between different types. Some of the other questions that you had are more about getting her reconnected and things like that. And I can tell you that we are very familiar and connected with her. But if you want, I can ask Laurel to share my updated email, and then maybe we could just talk offline, and I can reconnect and things like that. But there also is, there's an
Go ahead, Shawna.
there's an updated paper that I'm just publishing. Hopefully will come out in Brain soon, and it's specifically looking at CMT2A and progression from childhood to adulthood. So we think it's going to be a pretty impactful paper, and we've partnered with the INC sites and the London group. So my colleague Menelaos and I are the first authors on that paper, and that will have a lot of information about CMT2A and progression. But I think a lot of your questions were sort of guidance and reconnections, and we can do that too offline.
Thank you so much. Thank you.
Yeah.
We
Okay.
have time for just one last question, and then we're going to end, and then have you send your questions in to us if we have not gotten to you.
Let's do that. Okay, so the last question will come from Evan. If you could unmute.
Hi, so I'm asking this question for my son. So my 6 years old son, he's diagnosed with CMT2A. So I just wonder, so how accurate this their genetic diagnosis? So I be receiving some emails from CMTA about clinical trial that's possible gonna happen.
Mas
So I
está في
wonder,
l'anglais.
Can you
That's
unmute
long.
that person, Laurel?
I'm trying to find them. Please mute yourself, guys.
Got it.
There, thank you. Thank you,
thank you.
Laurel.
So I just wonder, how accurate is that genetic testing, and if there's some gene therapy clinical trial available in the near future. I mean, do we need to test him type? And also, we are working with Dr. Herman in Rochester. So if those trials comes out, should we work with directly, or to go through the doctors, and how does that work?
Thank you.
Yeah, so CMT2A is one of those that is very close to clinical trials, either gene therapy or also genetic editing through CRISPR-Cas9 is also, there's a few different things that are on the horizon for CMT2A that are all kind of happening in tandem. So we expect that that's going to be, just like CMT1A, that's going to be coming along the pipeline here. In terms of accuracy of testing, all clinical labs have to be CLIA approved. So it's separate from the FDA. They have to be approved by a process called CLIA certification that ensures their accuracy. And so it makes sure that they have a percentage of, a high level of percentage of accuracy so that they're not giving false results. But if you're connected with one of the specialty sites or a physician who knows about these types of conditions, they can look at your genetic testing and compare it to your clinical symptoms and make sure that that's accurate. But most of the testing is going to be accurate. It's just interpreting it is the more complicated part of that. But the answer really is that we have a lot of cautious optimism. There's a lot on the horizon for some 1A, 2A, and a lot of the data that we're publishing on 2A is going to be very important because we're doing 4 clinical trials specifically for that type of CMT. So it's an exciting time as a genetic counselor. It's an exciting time because it changes how I'm speaking with families, because in the past we've just said, and there's nothing we can do about this right now, but now we're saying, and these are the things that we're working on and that we will be doing about it in the future. And so that's a very different place to be. I know it's not at the speed the families want, but it's changed so much over the past 15 years in this field that I really want to give you guys, inspire hopefully a lot of hope.
That's
that,
right.
this moving forward, we will be able to, lead to a place where we're actually treating different types of CMT.
I want to thank you for that.
Thank you.
It ends this Zoom meeting with a lot of hope and promise, because we have come a long way, and with our STAR initiative and working with excellent people at the Centers of Excellence, there is a lot of hope and promise. So Laurel, how would you like to handle questions that we did not get to today?
Everyone can reach out to me. Most of you probably already received an email confirmation from me yesterday with the Zoom meeting link, but I'll also share my email address now. And it's very simple. It's Laurel, Laurel, at cmtausa.org. So please feel free to reach out anytime. I do respond to all emails. I'll even double check my junk folder to make sure nothing went there, but we will try to get to your questions as we're able to. And thank you all for being here today.
Thank you
I
all.
have one last question for Shawna. Is there an easy URL for the INC, or should we just send it out to the people that were on this call?
Yeah, I can send you our link, or
We'll send it out to you by email with our follow-up. We are
I
sending.
don't know that it's so easy, but
Yeah, right. But we are sending out a short survey after, just so we can continue doing these meetings and meeting your needs. So please fill it out. And if you give a positive feedback, then we'll send you that link. And it's no, I'm just kidding. Send us any feedback you want. But thank you to everybody for making this call. It really means a lot to us. And Shawna, thank you for taking the time, and Laurel too. It was
thank you for
very
being here
educational.
at home.
Take care.
Thank you so much for working for our community. Appreciate it. And have a good day, everyone.
Take care. Bye-bye.
Bye-bye.